Hello there, this is John, and this is the EMGM 106 course lecture for Medical Control and Specialty Resource Centers. So first, there's about 18 emergency rooms open 24 hours a day, 7 days a week in the county of San Diego. These are considered they're called BEFs, Basic Emergency Facilities, and they treat sick and injured patients all the time. Some of you guys might have gone there yourself as patients. Uh, as EMTs, if you do work on an ambulance here in the county, you're going to be visiting most of these, transporting patients to these facilities. There's two scenarios that you'll be encountering. The first one is you're on an ambulance, you encounter a patient who's sick or injured, but they are stable patients. They have minor injuries, minor illnesses, their vital signs are stable, there's no other extenuating circumstances, and they or their family have requested a specific hospital. So let's say they requested Kaiser Zion. So what you're going to do is once you get done assessing your patient, they're in the back of the ambulance, you're going to get on the radio. Most BLS ambulances, probably all of them in the county, have two frequencies for hospitals in their ambulance radios. So they have a BLS radio frequency, and all these 18 hospitals are listed in this one set of channels. So you're going to dial down to Kaiser Zion, and you're going to hail the hospital and say, "Hey, this is BLS 25." And what's going to happen is a nurse is going to answer the radio in the emergency room at Kaiser. And you're going to tell them what's going on. You're going to tell them who you're bringing or what you're bringing and your ETA. And they're going to say, "Thank you very much." And they're going to hang up. So this is a stable patient going to a requested facility, no matter what that facility might be, one of those 18 that we already talked about. But one thing the nurse cannot do is the nurse cannot provide you with any kind of medical direction or advice. So the second scenario is you have a patient that you need advice for. You need additional doses of medication. You have questions about destinations and treatment and all that. In that case, you need to call a base hospital. Now, base hospitals are also basic emergency facilities as well. They just have this extra resource kind of attached to them. They're licensed in the county of San Diego to provide pre-hospital care providers medical direction over the radio. So when you call a base hospital, you can ask questions. You can request additional doses of medications. You can do other things as well. And so consequently, it's like having the doctor in the room with you on scene. These are the 7 that are licensed in the county of San Diego. But it's a really great resource for us. And there's actually a protocol that gives you the criteria for when you as an EMT would need to contact a base hospital. It's an S415. Here's the list right here. It's pretty straightforward. I mean, obviously, someone with critical burns, you're going to go to the burn center, you got to call. You gave some kind of medication yourself, one of those EMT medications that you carry on the ambulance or the patient might have themselves. You have a critical trauma patient going to a trauma center. And again, any questions about the patient's status or destination, give them a call. It really does help to have that doctor over the radio to help you with making these decisions. Other centers that are also part of a BEF, there's stroke centers and there's STEMI centers. And you should have learned about these already. Stroke centers are for people with obviously strokes, CVAs, and of course STEMI centers are for people who are having myocardial infarctions. I know that you learned that heart attacks and strokes are medical conditions, but based on the pathophysiology of what's going on, there's brain tissue being damaged, there's heart muscle being damaged, depending on which one here. And in my interpretation of this is these organs are having a traumatic injury occur. So if this person were shot or stabbed or fell from a great height, you'd want to transport them to an appropriate trauma center as quickly as possible to maximize their chance of survival. Well, there's really no difference. If your brain is dying or your heart is dying, the sooner you get to a stroke center or get to a STEMI center and get treatment started, the better chance you have of survival. So you might drive past 2 or 3 other hospitals to get to one of these things because it's really the best thing to do. Trauma centers. There are 6 trauma centers in the county. Pediatrics, of course, is children's. Pediatric is any child who appears to be 14 years of age or less. There's level 1 and level 2 trauma centers. Level 2 trauma centers usually only handle 15 years in age and older, so adults, based on the county's protocol anyway. The one exception here is UCSD Hillcrest. They handle everything: pediatrics, adults, burns, hyperbaric. There's been some talk about Scripps La Jolla and Scripps Mercy also attaining the level 1 trauma center designation. I'm not sure if that actually happened yet or not, but I know for certain right now is UCSD is still level 1 and has been even longer than I've been a medic, so a long time. Other resources, so labor and delivery departments. You have a patient who is 20 weeks or greater in gestation, and they're having some type of pregnancy-related emergency, they should go to a labor and delivery department for best treatment. One caveat to this is some of these L&D departments have what's called NICUs, and NICUs stand for Neonate Intensive Care Units. These are really necessary if this patient is going to give birth to a premature child. So if you have a patient who's having contractions early in their pregnancy, 24 weeks, 30 weeks, 31 weeks, whatever it might be, well before full term, that's a preemie. And they need to go to an L&D that has a NICU that's open and available. So again, you don't want to call the base hospital, explain what's going on. They'll direct you to the closest NICU that you can get to in the shortest amount of time. There's a burn center, one burn center in the county of San Diego, which is UCSD Hillcrest. And again, you'll learn about burn center criteria in your trauma lectures and who to take there, who not to take there, and all that. A hyperbaric chamber, there's only one emergency hyperbaric chamber here in the county of San Diego, and that's going to be at UCSD Hillcrest. Scuba diving emergencies, carbon monoxide emergencies, they can all go there 24 hours a day, 7 days a week. There's one psych facility. It's a county psych center. It's like Rosecrans and Interstate 5. Again, if you have a patient who's having suicidal ideations or they're having some kind of psychiatric meltdown, they'll wind up probably being in custody or in some kind of hold, and you'll be transporting them to that facility. Legal goodies. So I know you learned about AMAs in probably the very first day of your 105 class. I wanted to clarify the county's stance on this. These are high liability calls for us. So an AMA means against medical advice. So it just basically means that you are really concerned about this person's condition. You're concerned if they don't go to the hospital, they could be seriously injured, or they could be sick, and they could die. You express that to them. If that person falls within this AMA criteria listed here on the screen, they're over 65, they're a high-risk population, they're really young, they're really old, they have really significant problems going on, their vital signs are grossly abnormal, you need to call a base hospital to get this AMA approved before you can release the patient. On the other hand, if you have a patient who has a single complaint, it's a mild complaint, the vital signs are normal, they're not part of that high-risk population, they're young, healthy people, 20-year-old male who twisted his ankle at the beach, something like that, you can have them sign what's called a release of liability, and it's a contract between you and the patient saying that you and the patient agree that they do not need to go to the hospital by ambulance today, and they'll seek their own medical care elsewhere. And they sign, you sign, no base hospital contact is required. There's a third use for this type of protocol, and it happens fairly frequently. I'll give you a for instance. So you have a patient who's been in a traffic accident and they have neck and back discomfort. They want to go to the hospital, but you want to put them in cervical spinal immobilization. And they say, no, I'm really claustrophobic. I don't want the collar. I do not want the backboard or the straps. I just want to go to the hospital. So at this point, this is a risk for them because they have neck and back pain and they could have neurologic damage and all that. So you're going to explain to them that, this is what's going on, the risks and complications up to including death and the recall of 911. And what you can do is you'll fill out your normal patient care report that is associated with the transport, but you can do another one as well that's associated with the against medical advice, and you can have them sign it, refusing a specific treatment or destination. And sometimes what happens is that you have and this happens a lot with trauma patients, is you think based on what you heard and what you see, this person fits the trauma criteria for a trauma center. The patient says, no, I'm a Kaiser patient. I want to go to Kaiser. And again, if they refuse going to a trauma center, you want to get the base hospital involved in this as well, but you could have them sign this stating they understand the risks and complications. Law enforcement at scene. So when it comes to these calls, we go on them quite frequently. Basically, they're just medical evaluation calls. The cops may be in the process of arresting someone, they got roughed up a little bit, or whatever it might be. More commonly, what happens is we have this condition in the county of San Diego. It's a terrible disease process. It's called incarceritis. And how this works is that someone gets arrested for something, shoplifting, theft, felony, whatever, and they know they're going to jail. So suddenly, as soon as the old handcuffs get clamped on their wrists, they suddenly get chest pain. They suddenly get short of breath. They suddenly, whatever it is, they suddenly have some problems that they got to go to the hospital because they have this idea that if they go to the hospital, they'll avoid going to jail. It doesn't work that way, unfortunately. Ultimately, you get called out on these calls pretty frequently. When you arrive on scene, the first thing you should do is find the arresting officer. I don't care if it's CHP or sheriff, whoever it is, find out who's arresting officer and find out the status of the patient or the person. Are they in custody or are they detained? If they're actually under arrest and in custody, then the police officer, the sheriff, the CHP officer has the consent for the patient. The officer makes all decisions about the patient's health care, whether they get transported or not, and even where they go to some extent. If the patient's been only detained, this happens sometimes like traffic stops. They stop someone who's suspicious, they get them out of the car, they handcuff them, they put them on the curb, and they do a background check on him. And in the meantime, the guy gets chest pain. If this guy's only detained and not under arrest, that patient still has a right to refuse care, treatment, and transport. So it's really a good idea to figure out where you stand at that point. When it comes to destinations, if this person's in custody, the police officer makes the decision about what hospital this person needs to go to. The way this works is every single law enforcement agency that I know of, they have contracted with specific hospitals to give them discounts. Because if you get arrested and I transport you to the hospital and you're in custody, that agency, that police agency, pays your medical bill and your ambulance ride. So consequently, they want to go to the cheapest hospital, which is the one they're contracted with. Now, that might not be the best hospital for the patient's condition. So if you feel that the destination isn't appropriate, explain to the arresting officer why you think it is. They're very, very, very worried about liability and things like that, especially nowadays. So they'll probably take your advice. All the years I've done this, I've never had a police officer not take my advice when it comes to destination. trauma center, burn center, those types of things. Lastly on this is if you are going to the hospital with someone in custody, they're going to have, at the very least, handcuffs on, maybe plastic ties, even body wraps, whatever it might be to restrain this person. If they have any kind of police installed restraint systems, the officer has to come with you, either directly in the back of the ambulance, which really is the safest thing to do, or at the very least following behind you in their vehicle, close behind you. Working with medics. So if you work here in the County of San Diego as an EMT, you're going to eventually wind up working with paramedics. Falk Ambulance, AMR, they all have medic units that have BLS, EMTs working with the medics. Pretty much every fire department that I can think of in the county has ALS and BLS ambulances in their fleet, and they hire a lot of EMTs as drivers, as helpers, basically, for the medics. Medics in particular, they're rather high maintenance, and I apologize in advance, but it's an amazing learning experience for you if you want to go to be a medic, or you want to go on to nursing school, or even medical school. It's a great environment to learn care and treatment of the sick and injured. But medics really focus heavily on the ALS side of it. So you're there to do all the BLS stuff, the grunt work. You're going to be attaching the EKG leads. You're going to be spiking IV bags and hanging them up in preparation of the IVs being established. You're going to get blood sugars, oxygen saturations, end titles. You're going to be the splinting and bandaging and all that stuff that the medics aren't going to want to do or don't have time to do because they're busy doing other things. So I've got a few videos that cover this kind of stuff, so I'm not going to get too in depth here. But a lot of what you're going to be doing is you're going to be attaching EKG leads or ECG leads, if you're talking about the English language version, I guess, of this. And you can see the upper picture right here. There's 4 leads, which is really a common configuration. There's 4 wires and 4 leads leading from the machine, and they go into these 4 areas. They're called limb leads. They're normally, years ago, they would go on the backs of the hands and the soles of or the tops of the feet. But because of our environment, how unstable our environment it is, the moving of the ambulance, the artifact and all that, most medics prefer them to be on the torso, as you see from the picture here. Indications vary depending on who you talk to, but this is just kind of a short list of what reason why you might need to put them on. As you work more and more in the field with medics and you understand the reasoning behind why you're putting these leads on and when you do it, you'll be able to anticipate the medic's needs and actually put them on even before they ask. But again, just the indications vary. Now, the 4 leads only provides what's called a non-diagnostic view of the heart. It shows a waveform, but I can't really tell as a medic exactly what's going on in the heart. So if I am concerned about a cardiac or a syncopal episode or something else going on, I can have you attach 6 more leads. And you can see the lower picture, and these are called V leads. And the V leads, along with the upper 4 leads, that's 10 total leads now attached to this person. This gives me a 360-degree view of the heart, and it actually is diagnostic. I can look at the waveforms, I can look at the shape of the various waves, and I can tell if they're having a heart attack or not. So again, you'll be doing all this stuff for your medic partner. Intravenous fluids, there's generally 3 common size IVs, 1000 cc, 250 cc, and 100 cc. There's occasionally you'll have 50 cc bags as well. Really what it comes down to is if you need lots and lots of fluids because this person's losing blood, you're going to go for the 1000 cc bag. If your medic is going to give medications intravenously, then more than likely it's going to be the smaller bags, depending on the type of medications that he's going to be doing. There's 2 different tube sets. There's a 10 dropper and a 60 dropper. And again, you'll pick those, whatever tube set aligns with whatever size bag you're using, which best administers the fluids. You'll be spiking the bags. You'll be basically draining the fluid through the tubing in preparation for the application to the IV. You'll hang it up, and then the medic will do everything else pretty much. You already learned about blood sugar monitoring. You got signed off on it, obviously, at this point in the conversation. Just wanted to remind you that it's not just for known diabetics. Anytime someone has any kind of altered neurologic status for whatever reason, alcohol, drugs, stroke, seizure, anything like that, get a blood sugar on them. You never know. Oxygen saturations, I mean, obviously you've been in the labs, you've used the pulse oximeters, you understand hopefully the concept of all that. There are some drawbacks. They're not very accurate if the person has cold hands or fingernail polish and all that. So I just wanted to bring up that in the field anyway, we do have these adhesive probes, these pediatric probes. You see a picture of it right there. What I've done in the field, because the extremities are always colder than the core, the head, neck, and torso and all that, what you can do is take your little pediatric Band-Aid, you can fold it in kind of a U shape and place it on their earlobe and stick it to their earlobe, because it is a Band-Aid, and the red beams through the tissue, and it picks up pretty accurately their oxygen saturation levels if they are not perfusing very well in their extremities. End-tidal carbon dioxide sampling. So again, this is an ALS skill, but you're going to be attaching these things for the medics. Now, there's two types you have on the ambulance and also the fire truck as well. You have an inline versus nasal. So inline, as you can see, it's inline between the BVM and either the advanced airway tubing or even regular old BVM mask. It works for either of those. As this person exhales, gas comes out that little tiny tube and goes to the monitor and creates a waveform. And that bottom brown waveform, that kind of boxy form on the screen there, that's the waveform of this person breathing. So how this works is when this person exhales, the waveform rises up, it plateaus, it goes across. And where it comes all the way to the right, just before it drops back down again, that's the end-tidal point. That's the highest point, and that's the most carbon dioxide that has been exhaled. As this person goes to breathe in, or you ventilate them, the waveform is going to drop back down to the baseline, come across to the next waveform. The idea behind this is that there's an ideal amount of carbon dioxide in the body, 35, 45 range or so. And so consequently, we want to get this person in that range. So if I'm having you do bag valve mask ventilations, you can watch this monitor, you can watch the waveforms, and you can look at the numbers. And by adjusting the depth and the rate of your ventilations, you can change this person's carbon dioxide levels for the better. So if you ventilate a little faster, they're going to blow off some of that carbon dioxide. If you ventilate a little slower, it's going to build up. So you want to try to get in that range as best you can, because that's where the pH level is the best for the body, and the cells function the best in that optimal 7.35, 7.45 pH level that the human body operates at. Now the nasal one, this person is going to be breathing normally, but they have some kind of neurologic thing going on. It could be a stroke. They could be overdosed on drugs, alcohol. They could have had a seizure. As a medic, I'm concerned about this person maybe not breathing in a few minutes, or they might stop breathing, or the breathing might become ineffective. So I have you put this thing on their nose, and it looks like a nasal cannula, because it really is a nasal cannula. You can actually hook it up to oxygen and give them 1 to 6 liters via this device, but it's got that little cup there, and the cup actually traps the carbon dioxide that's exhaled, and it creates a waveform as you see in the picture. So as we're going to the hospital, you're driving me to the hospital, I'm in the back with the patient. The patient stops breathing, or their breathing becomes ineffective. There's an alarm goes off, and it wakes me up like, hey, this person's not breathing now. I should do something about it. It's a great way to monitor this person's depth of respirations, rate of respirations, and also their CO2 levels as well. Really amazing. Lastly on this are BLS downgrades. So one scenario here is the most common is when a 911 call is generated here in the county to a dispatch center, a computer program decides whether it's ALS or BLS. So let's say something happens, someone calls 911 and the computer says ALS. So medics arrive at scene, they do a medic assessment to this patient, and in the process of the assessment, they realize this person's totally stable. And so they call dispatch and they request a BLS ambulance with 2 EMTs on board. So you get dispatched, you're driving towards this call where the medics are waiting for you to arrive. In the meantime, while you're driving to this call, the medic on the ambulance or fire engine, whatever it might be, calls a base hospital and says, hey, I've got a BLS downgrade, explains the circumstances, and the nurse on the radio gives them permission to downgrade to you guys. Ultimately, the patient must be stable patient. They cannot be, in shock or having a stroke or a seizure or anything like that. They got to be a stable patient. If the medic did a EKG, if they did a blood glucose, if they did just the basic stuff, it doesn't really count. You can still transport them. If they provided a single dose of one of these 5 medications on the screen, whether it's Narcan, dextrose, glucagon, Zofran, or Tylenol, if they only provided one dose and there's no anticipation of needs of more medications or more ALS treatment, you can transport this patient in your BLS ambulance. If you think, as an EMT, you do your assessment and you think that this patient is not stable, or you think that this person might need no more Zofran because they're getting nauseated again, or they're still in pain and the Tylenol's wearing off, and you don't think that, it's a good idea you transport, you can respectfully decline. It's county protocol. And then the medics would then transport. Now, there's one more scenario that's very common. We have a very big call volume in the county of San Diego. And there are times when there's literally, we go to what's called level 0, where there's not a single paramedic ambulance available anywhere. And this might go on for a few minutes or even a few hours sometimes. So if there's no ALS units, they're going to send a BLS ambulance to whatever call it might be. So you arrive at scene, you and your partner by yourselves, you encounter a patient who's they're critical, they're really sick, they've been seriously injured, and you really need a medic. And you call hey, dispatch, I need ALS right here, right now. They don't have any ALS, or ALS is delayed. So if ALS is delayed or there's no ALS available, then you transport. Now, this is going to be your decision. And the county didn't really define what delayed meant. They didn't give us a number. They didn't say 10 minutes. They didn't say 15 minutes. They just said if ALS is delayed, BLS should transport to the closest appropriate hospital. So it's going to be your decision, your critical thinking. This is why it's so important that as an EMT working out in the field, you're familiar with the various resources around you, the hospitals, the stroke centers, the STEMI centers, the trauma centers, and all that we talked about. So hey, I'm here, and Mercy Hospital is only 7 minutes away over there. The medics are going to be 20 minutes to get to me. We're going to transport. Even if it's a CPR, you're going to transport. Because why would you sit at scene, with a critical patient, a stroke, a seizure, a heart attack, when, you could be at the hospital in 5, 6, 7 minutes or so. So again, it's going to be your choice, your decision. But that's why it's important that you understand the resources that are available to you. And I think we're totally done here. Yes, we are.